So our speaker for the evening today is Dr. Sam Most. He's the Chief of Division of Facial Plastic and Reconstructive Surgery at Stanford University. He will talk about functional and aesthetic consideration in crooked nose patients. Some years ago, he developed the anterior septum reconstructive as an alternative way to correct severe deformity. Before that, many of type of patients were managed with extracorporeal septal technique, and unfortunately, we have a lot of crooked nose patients, and sometimes it's a challenge to manage that. I will stop from here because it's better to learn from the master. We are really happy to have you here today to talk about this topic. But before we start, I will introduce the other guests with us. We have today Dr. Julia Jorge and Dr. Ingrid Cianco. Both of them have the pleasure of watching Sam most closely at Stanford. We also have the presence of Dr. Carlos Caropreso, our head of facial plastic surgery at University of São Paulo. Welcome everyone. Sam most, now I'll pass the words for you. Whenever you're ready, you can share your screen.
Thank you very much. First, I want to say thank you. It's an honor to be here. I want to thank all of you, Dr. Loureiro, Dr. Jorge, Dr. Cianco, Dr. Caropreso. Thank you so much for having me. I wish I could speak Portuguese. Obrigado is all I know how to say. So thank you very much. I'm going to try sharing screen here. And we're going to talk about functional and aesthetic considerations for the crooked nose. Can you see the screen okay?
Yes, that's
good.
Fine.
Very good. And let me know if at any point the slides don't advance or any problems happen with Zoom. You know, sometimes it works great, sometimes it doesn't. I have no disclosures, and the slides are advancing. You can see, okay, good. And this is my contact information for anybody who has questions about this or wants to see other examples. Feel free to contact me. And, you know, I've thinking about crooked noses. This was really good for me to put together a little bit of a longer talk to talk about my concepts that I consider most important in rhinoplasty, and particularly in dealing with crooked noses. And I always show this at the beginning of rhinoplasty talks, and I think this is all, it really can't be overemphasized, and that is you should always consider aesthetics and function hand in hand. Because all your patients, these are going to be important things to think about. And, you know, rhinoplasty, and I've shown these first couple slides many times, and I just want to reemphasize this. Rhinoplasty is defined in the dictionary as a cosmetic surgery, but really it has to be considered both functional and aesthetic. And anytime, if you've done rhinoplasty enough, you realize that while what we do surgically is concentrate on the cartilaginous and bony framework, in order to influence the external lining and tent up the internal mucosa if necessary. Really what we're doing is we're working on aesthetics, which are light and shadow and the way the light hits the nose, contrast, highlights, and functionally we're looking at the airway. And both of these things balance. Hopefully they balance, and you don't want to take one solely at the expense of the other when you're doing a surgical procedure like this. And so this tension in rhinoplasty is a theme that I stress, and I think that you'll see in these examples and what we talk about that these go hand in hand. And just a quick plug for this, because you're going to see now, I'm slowly transitioning all my talks to show not only the physical results, but the quantitative results for these patients based on this questionnaire, which is what we've developed as part of our research program. And this questionnaire is highly validated, translated into 9 or 10 languages, including Portuguese, and will measure obstruction and aesthetics, and is like a guidebook for you as you take care of patients. So for every patient I show you today, I'll show you this if I have this data. If the patient is, you know, prior to 2016, then I will not have this data, because that's when we developed this questionnaire. And this is, of course, the Portuguese one. This is freely available, by the way. There's no cost to this. So you can, if you need it, you can contact me or Lucas Patrocinio, he has it, and we can just give you it as a Word file, and you can incorporate it into your practice. So that's just my quick plug about that. But I think that, you know, as I get older, have more gray hairs, and I think about all the cases that I've done, you know, I think that this is very true. And this is that the eye can't see what the mind doesn't know. When I used to look at faces and noses, I didn't see things that I see now. And you can't really understand what you need to treat in the patients unless you actually, you know, you won't be able to synthesize in your brain what to treat and what to do about it if you can't see it. And as you start looking at faces more and more and studying noses, you'll start to see how asymmetric we really all are, myself included. And so, you know, I've kind of narrowed this down to something I called occult midface asymmetry. And I didn't define it because this slide was taken from another talk just on occult midface asymmetry. But if you look at most faces, the midface, which is the base of the nose, is asymmetric in most people. And these, there are overt midface asymmetries, which are easy to spot. And the classic example, of course, is a premaxillary asymmetry in cleft nose patients. But if you look closely, you will actually see occlusal abnormalities and facial asymmetries in the midface very commonly. And often this is the base of where the rhinoplasty, the asymmetric crooked nose and rhinoplasty comes from. And so the first step in solving a problem is recognition. This asymmetry in this area was found in this paper by Hashim Saleh, who's I think now president of the European Academy. This paper is from 13 years ago. I thought it was nice because they looked at what variables in terms of facial asymmetry seem to be most important to casual observers. And this distance from the midline to the alar base is one of the most important ones. And this goes along with midface asymmetries and how that's really important in you know, placement of the ala and what we notice when we look at a face and find asymmetries in the nose. And people have tried to quantify asymmetries of the nose and kind of come up with pattern recognition and, you know, what tendencies tend to occur. I'm going to show you this paper. I don't completely agree with the findings, but they basically, which was interesting, they took 500 and something patients, this was in Tehran, and they looked at patterns of asymmetry, which way the nose deviated, for example, which cheek was higher than the other and so on. And they came up with this idea that the cheek tends to be deviated on the higher, towards the higher side. Well, I just showed you a patient, the nose was deviated towards the lower side. So I'm not so sure it's totally true. You know, this patient actually, her cheek is lower on the right and her nose is deviated to the right. So it's the opposite of what they said. But the point of what I'm trying to say is that people have tried to classify these things. I'm not so sure it's really so important as it is that you analyze every patient and come up with a plan to fix it. And so patients often ask me, what's the big deal? Okay, I have a crooked nose, just push it to the straight position. It's a lot more complex than that. And one thing that I've found is useful to not only teach this, but to talk about it with patients is to say that think of a home that you're building and think of the foundation of that home. Now, if that foundation is not flat, it's really hard to put up a home that goes straight up and down. So the foundation, you know, these foundation pillars, this is an A-frame type home, which is like a ski type home or something in the woods, in the mountains. They build them on these pillars that hold them up. And of course, these things have to be level. And the same thing happens if you look at a skull. And you look at this is a skull from my office. I took this photograph. It's a plastic skull. If you think about the base of the bony cartilaginous pyramid, you can think of it as a foundation for an A-frame home. And, you know, this foundation has to be stable and symmetric. If it's not, you're going to get asymmetric noses, things that are pointing the wrong direction. It doesn't matter how much you do to the bone and the cartilage up above, but the foundation has to be very symmetric. And if you look at some patients, this is a CT scan, or a rare scan that I did on a patient. I don't usually do CT scans. It would be nice if you could do CT scans on everybody. This patient came to me with a dorsal hump, and when I saw him, which was later in my career, wasn't the first 5 years, I really saw all these facial asymmetries, and I couldn't get past the fact that his maxilla to me on the left looked extremely hypoplastic, to the point where I was concerned about silent sinus syndrome. Even his orbit is asymmetric if you look at this. So I got a CT scan, and they did 3D imaging, and you can really see how asymmetric he is. If you look at his occlusal cant, the occlusal plane is higher on the left than the right. It's tilted. His left midface is shorter. He has severe distortion of the base of the piriform aperture. And the funny thing was, he didn't even notice that his nose was deviated. He only saw the dorsal hump, and that was all he cared about. And that's a real pitfall. So it's really important that when you see these patients, I'll show the top view. You can see this asymmetry here. You can see the orbital asymmetry. When you see these patients, you have to take the time, and it's a delicate thing to talk about, but you need to talk about their facial asymmetries with them. And it's delicate because some of them don't realize what's happening. And you have to kind of explain to them why the base of that foundation, the foundation of that nose is asymmetric, and why you may not be able to get things perfectly straight. Because one of the most important things I can stress today, and I have a slide later on this, one slide, but I'm going to say it over and over, is you really can't make everybody 100% straight, no matter how good you are, for a variety of reasons. And you need to set expectations in that way. I usually tell patients, I can make you straighter, I can make you better, but I can't make you perfect. I can't make you perfectly straight. It's just not possible. I can say it, but it's not true. So, I try to level expectations a little bit. This is, to me, a very favorable patient for fixing a crooked nose. And the reason why is these guys all line up, which is pretty rare. The subnasale, which marks often where the nasal spine is in the midline of the piriform aperture, the glabella, and the philtrum, and the Cupid's bow, they're all lined up. This was a post-traumatic injury, post-traumatic deviation. So he was born with a fairly midline straight structure. He's fairly symmetric otherwise. This deviation you can correct, and you don't have all these other things working against you. We'll show what we did for this patient later. This patient had a rhinoplasty previously, and came to me for a revision, and her primary concern was the deviated nasal tip. And so, when you look at these patients, you see the subnasale is a little bit off to the right. The Cupid's bow isn't perfectly lined up with the glabella, but it's close enough. But really, if you can get that tip into position, it'll make a big difference. This patient had a maxillomandibular advancement surgery. And I don't know that this caused the deviations and asymmetries that she has, but I think now you can see, if you look at her oral commissures, they're it's not perfectly level. And if you drop a line down from her glabella, it doesn't line up with the tip, the subnasale, or the philtrum. So you're not going to change the position of the lip by doing a rhinoplasty. And the question you have to ask yourself, and I often ask the patients, is, if I put your nose straight up and down, it wouldn't line up with your mouth, and that wouldn't look right either. And then I explain that all of our faces are asymmetric, and my preference is generally to try to line up the tip of the nose over the philtrum, and as straight as possible to the glabella, but it would look very odd to switch it completely over if it doesn't line up with the mouth. Moreover, it often will block the piriform aperture. If you put the septum where that line is, it'll probably block her left nasal cavity. This is another patient where the glabella kind of lines up with the midline of the upper lip, but the tip and the subnasale are off to the right. So it's another example where probably his nasal airway would be affected if you completely shifted his nose over to the left. These are all patients we're going to talk about in just a little while, by the way. Another one. This is a multiply operated on traumatized nose who had actually a significant accident. So he had other trauma surgery before he came to me. And, he's pretty good. And I think, that's close enough to lining up that he'll be a good candidate for reconstruction of the entire thing without blocking the airway. So this is the slide, okay? Manage expectations because we as surgeons cannot make noses 100% symmetric. And that's just the truth. And it's not because, and I tell patients this, and I also say, I'm not making an excuse. I'm telling you the truth. And I will do everything I can. And sometimes you look perfectly symmetric on the operating table, and 1 month after surgery, you still look perfect. But over time, things can shift a little if the foundation isn't perfect, even though we try to fix that. And, you know, I would expect some asymmetries over time. And I think that managing expectations that way is very reasonable, and it's our duty as surgeons to do that and not overpromise. But let's now get into the nitty-gritty of surgical approach to these patients. Again, there are multiple great surgeons who have come up with classification schemes for crooked noses, twisted noses, all sorts of things like that. To me, I like to divide and conquer and think about where the asymmetries lie and what I can do to address them. So I generally divide the nose into thirds in my mind. The nasal bones and upper septum, the mid-septum or mid-vault area, and then the tip caudal septal area. And this is a scheme you can kind of see here. I'm trying to show nasal bones in light blue, septum in green, and the alar cartilages in that purple. And on the right side, you can see the base view showing septum in a trapezoidal structure. So we're going to use this schematic as we talk about different types of noses. And, you know, so there are a few different examples here of different types of deviations you can have. And you can call it A, B, C, you know, most classification one. That doesn't matter. What really matters is when you look at these, you analyze them for which way each third of the nose is deviating and what you can do to try to address that. So let's talk first about this type of a situation where the bottom 2/3 is the main issue. The upper third is relatively okay. And in these cases, you know, often it's septal deviation, either dorsally or caudally or both, and resetting of the nasal base that's necessary. And, you know, there's sort of relatively simple solutions and relatively, you know, more radical solutions. Whenever you look at a nose and you want to do something to change the shape, you can think about what you're going to do structurally to try to change things, and then also whether they're relatively simple things, such as camouflage grafts or things like that, which can aid what you're doing or be the only thing you need to do to fix any asymmetries in external light and shadow. So think structure and also camouflage as two different kind of major ways of doing things. I think this septal rotation suture, which to me was just really a revelation when I saw Baumann Gairan talk about this at a talk 10 years ago or something. Really cool. It's a very nice concept. I'm always dubious of sutures holding things in position, but I think that this works pretty well. And we actually published a paper on this as well, just looking in cadavers at, you know, what the angles and differences in offset for sutures are that are important. Basically, what you're doing is a repair suture from the upper lateral cartilage to the septum, the dorsal segment. And rather than going straight across, you can use the upper lateral cartilage as a relatively fixed point and use it to coapt the septum over towards that side if you offset it by a certain number of millimeters. And so Baumann calls this a clocking suture or a septal rotation suture. And that's a really nice technique if you have minor deviations of the dorsum that don't require reconstruction. You can sort of angle it a few degrees one way or the other if you have a minor deviation there. So sometimes you put a spreader graft in or something, but the tip of the nose is still slightly deviated to the side because it's canting one way or the other. This type of suture can help, and I'll show a video of that in a minute. When the caudal septum is severely deviated, I like to do a modified extracorporeal septoplasty, as was mentioned earlier, and first published this in 2006, and we've done multiple other studies since then. And basically, you know, I looked at what really the world leader in extracorporeal septoplasty, Wolfgang Gubisch, was doing. And, you know, he takes the whole septum out. And the problem with that was that there's a relatively high rate in the initial papers, 9 to 10, 11% rate of notching at the keystone, because it's really hard to reconstruct the keystone. And I thought, you know, why bother taking that out? Because you often don't need to, and you can structurally do the things you need to do for the airway, and you can camouflage other things if there's still a little deviation up there. And so this is the subsequent paper that we did, and we just recently this year published another paper on doing this technique along with dorsal hump reduction and how we can do that safely with full osteotomies and everything. So I would refer you to those if you're interested in that. But in this case, this is a revision rhinoplasty. And she probably, when she had her first surgery, had a caudal septal deviation, and it wasn't totally addressed. I'm guessing they made the tip smaller and sutured it onto the caudal septal deviation, and she ended up with a more visibly twisted tip. Probably went from subtle to obvious at that time. And these occult asymmetries need to be addressed at the time of primary rhinoplasty. And so for her, the problem wasn't functional. It was mostly cosmetic. And just to orient you again, I colored the top 4 questions in yellow, so you'll know those are the functional questions, like the nose questionnaire. And lower numbers are better, higher numbers are worse problem. So she doesn't have much of a functional problem, but if you look at the bottom 6 questions, which are the cosmetic questions, she is very unhappy with the way things are looking. And, so we're going to do this by doing an external approach. And for her, it was an anterior septal reconstruction to fix that anterior tip. And I anticipated needing rib graft because she'd had a prior standard L-strut septoplasty. But thankfully, enough cartilage was left over that we did this with septum. And a clocking suture was placed, as you can see there in the blue, to also shift things over, as well as, her tip cartilages were very small and pointy, and she has thin skin in her tip, so I placed crushed cartilage as a cap over the tip, and you'll see in an early postoperative photographs that she's still a little puffy there, but she's much straighter. So anterior septal reconstruction and clocking suture. So this is just showing you clocking suture. Is the video working? Okay. You can see it?
Yes, we can.
So here we are going through the upper lat, and then I went down about 3 or 4 millimeters onto the septal construct. So that's an anterior septal reconstruction suture to a dorsal strut. And then this is just to, make a little minute change. Now I've got the face covered, but normally we have all the marks visible so you can see that it's a little to the side. And then as we tighten this down, it's going to shift to the right. And by the way, use a permanent suture for this. I usually use a PDS in the upper laterals, but here I like to use a permanent suture. And this, you can move that tip a few degrees one way or the other if you need to. And I find it's very useful. So here she is 4 months after surgery, and she was supposed to come for her almost 1-year follow-up. So we're trying to get her back, hopefully with COVID. A lot of patients are not coming back right now. And she's much straighter. I anticipate this will continue. And her 3/4 view, now this is really telling because you can see the twist in the tip from this angle and the improvement there. And then this is her side view. And here's her base view. A little bit improvement from that twist. And as I promised, I'm going to try to show their scores postoperatively. So you can see here, she's actually happy with everything. She's still a little concerned about the shape of her nose from the side. I don't know if she wanted it even smaller, but we'll see how she does as the swelling goes down. But it really gives you a gauge, before you walk in the room, you can often tell what concerns are for patients preoperatively and postoperatively. But she's actually very, very happy with everything and functionally doing fine still. Here's the patient, as I mentioned earlier, who had a maxillomandibular advancement surgery and postoperatively, had a number of concerns about the profile and straightness from the front view. And this is someone you definitely have to counsel that, there is some facial asymmetry. You can't get everything 100%. And this is another good example of doing a structural approach and using camouflage also to help you get the best possible result. This is her preoperative schnoz score, functional and aesthetic concerns. So, again, off to the right, those are high numbers, they're extreme problem numbers. So she's having congestion, difficulty breathing through the nose, has a severe septal deviation, and she's scoring very high on all of the questions on aesthetics. For her, the approach was to perform an anterior septal reconstruction and premaxillary augmentation I'll go back here. You can see her premaxilla, especially with the advancement. In a patient of African American descent, you're going to have even more of an acute angle there. So it just looks totally collapsed. So we want to project her nose, augment her premaxilla. And so we design an anteroseptal reconstruction graft so that it extends into the premaxilla further. And it gives that premaxillary augmentation, which isn't what you normally hear. Normally you hear about crushed cartilage or something in there, but you can actually augment the premaxilla this way too. And doing this, I also, as I'll introduce in a few slides later, used a mini plate on the base of her construct. And the reason for that often is, the premaxilla, in the premaxilla, the nasal spine is gone sometimes in patients who've had an MMA. So she had no nasal spine. There was no way to really put this ASR graft into a groove, so I used the plate. And we'll talk about the indications for plates in a little bit. And then diced rib and tissue glue, which I like to do for dorsal augmentation and smoothing out her dorsum a little bit. She needed a little bit of augmentation. So here she is post-operatively. Some of the facial asymmetries remain. Her nose is a little better lined up over her Cupid's bow. It's not perfectly straight down from her glabella, but it actually looks much more symmetric because it's lining up with her mouth. Here's her profile, and you can see the increased projection, dorsal augmentation. I shaved her hump a little bit and put dorsal augmentation across there in order to get that profile better. But the premaxillary augmentation looks much more balanced. That isn't the purpose of this talk. We're talking about crooked noses, but that's just part of the analysis here. And you can see on smiling, the tip support is much better. On base view, you can see the projection. And these are her preoperative schnoz scores I showed earlier. And here she is afterwards. So she's got a little bit of congestion, but overall her breathing's much improved. And aesthetically, she's very happy with the way things are going. So let's talk about the next type. And this type is when the bones are deviated, and you need to address those. And this is sort of the classic crooked nose discussion. And in these patients, we talk about osteotomies and extended spreader grafts as a way to shift the pyramid over. And we've written about this extensively. It wasn't an original idea to do these open book osteotomies. I want to make that clear, but this is a chapter out of Papel, and we've written other chapters about it. And this is the way I was classically taught to shift nasal bones to the correct position. And I'll show you a schematic of how we do this in this video. And we want to shift the bones from the convex to the concave side. And so rather than doing medial then lateral osteotomies as we're usually taught, we do sequential osteotomies from the concave side to the convex side. It's what we call open book osteotomies. It's like turning the pages of a book. We do lateral, then medial to shift the septum over, and then lateral, and push the whole thing over to a straighter position. And so this is a video. Let's see. There we go. A video showing a sequential open book. Now this is obviously not my normal operating speed. This is sped up so you can, we can get through this. But so I like to make incisions and elevate a little bit of periosteum. And then in this patient, we want to move the bones this way towards the patient's left. You can see I've written 1, 2, 3, 4 on there. And so we're doing a lateral osteotomy on the concave side. And now we're doing the medial osteotomy. Then we try to elevate that. I'm elevating it into position. Then we do the other medial osteotomy. Try to push that over if you can. Of course, it's, if it's attached to the skull base, you have to be really careful. Sometimes you can actually do a percutaneous osteotomy to release that and then push the whole thing over. And finally, you just put some muscle into it and try to push the whole thing over. Now, of course, there's going to want to be memory to move things back into position. So sometimes you need to use extended spreader grafts and things like that. This is the patient I showed earlier that I think is a good candidate for this because he's otherwise pretty symmetric in terms of glabella to Cupid's bow. And he'd had a traumatic injury, so it isn't a congenital thing, even if it happened many years earlier. We can try to shift the whole thing over. And so he had some breathing issues as well. So he had a septal deviation. So we did sequential caudal septal deviation. So sequential osteotomies, 1, 2, 3, 4, as shown there, to move his nose in the direction of the arrow towards his left side. In this case, I did the ASR, but I also used a plate. And the reason for using the plate may have been at the time that he still had a tendency for this to want to shift, and a clocking suture wasn't enough. And I'm going to talk about rigid caudal septal fixation in a little bit, but this is another indication for using a little plate. Here he is 7 months post-operatively. I lost track of him, so that's the longest follow-up I have for him. I don't anticipate this changing after 7 months. It's healed into position at that point. He's much straighter, not 100%, but he's much straighter. Profile, I always counsel these patients, even if they don't want a profile change, which I don't think he did, that they are going to get a little profile change when you shift the bones over. This is just a small effect of shifting that whole nasal pyramid over. And here's his base view. And he does have a little bit of asymmetry of his base, but he kind of had a little bit of that before. He's okay with this. So I would call that a pretty good result. Here he is preoperatively and then postoperatively across the board, doing really well. Another patient. This is a patient I showed you earlier who isn't lined up in terms of glabella to subnasally to tip of nose and to the Cupid's bow. But we're going to do something a little modified for him. He has some breathing issues. And if you look at the blue area, the only concern he has with his nose is number 7, which is the straightness of his nose from the front. And that correlates with what you see and what his concerns are. I did talk to him, by the way, about doing a little bit of dorsal augmentation because I thought that it was a little bit low and we could make it a little more masculine by augmenting him slightly. So I did plan on that with him. So in this case, it was a single unilateral left medial osteotomy without a lateral, just to kind of bend the bone up a little bit, and then an extended spreader graft placed underneath it to keep that open. It also helped him with his airway. Anterior septal reconstruction for caudal septal deviation, and a camouflage graft on top of that structure. So when I did it, it wasn't enough to make him look straight. So the spreader graft, sometimes, you hear us talk about it, and it sounds great when you put it on the Gunter diagram, but in reality, it doesn't give you enough contouring. So camouflage grafting is fine to use in that situation. So here he is 1 year post-operatively, and he's got much more symmetry. And I augmented him slightly, which I thought looked a little bit better for his profile. So that was all we did in this patient. You can see here's the base view. These are all external approaches, by the way. And these are his pre-op schnoz scores, and here are his post-op schnoz scores. So doing very well, both from my eye and based subjectively on what he's telling me. So really happy about that. Here's a severe traumatic bony deformity that resulted from a sports injury, and really affected her self-esteem, and she had big concerns about it. She also had a really low radix area. She needed augmentation there. And so we talked to her. She liked her tip. She didn't want to do anything with that. I'll show you her scores here. So you can see the shape of her nasal tip is not a problem at all on the cosmetic side, but all the other things are straightness of the nose, shape from the side, overall symmetry, and she had breathing obstruction. This is someone I counseled that we were going to need a rib graft because I didn't think she had enough septum for us to do this reconstruction properly. And her breathing obstruction was primarily due to valve narrowing due to the bone and the sidewall being pushed in. So sequential osteotomies, this time using the piezo, which I like to use quite a bit now, an extended spreader graft to elevate that nasal bone and keep it in position, and a little bit of tip work. She didn't want anything much there. I just did a tiny couple millimeters cephalic trim and a tongue and groove to set that up. I did use a septal extension graft to keep the tip towards the right, which we wanted to go left. And then on top of all of that, in order to augment the radix area, which I thought was a little bit under augmented or under projected, I should say, and to also on top of our structure with our bony elevation, I noticed she still needed more. I put diced cartilage on top of that too. And so this is a video showing the piezo osteotomies, again at higher speed. And it's the same concept. That's actually the lateral. It looks kind of like it's not, but I've dissected the whole sidewall off. And then we're going to do the medial than on that side. And then we're going to do the medial on the opposite side, which I think is coming up. Maybe that's it right there. It's hard to tell, I'm sorry, with these, you know, exactly where we are. Here we are getting ready to do the medial on the other side. So we've elevated and started mobilizing things now. And then the opposite side, we're going to do the lateral osteotomy. And, you know, the piezo is nice. I don't think it's, you know, the answer for everything, but it allows you to do some finer work. In this particular case, because I was going to be putting dice cartilage over the sidewall, I knew I was going to dissect up that periosteum anyway, so I decided to use the piezo. And here we are elevating that nasal bone and getting ready to put in our extended spreader graft, which is right here. So this will really help keep that nasal bone propped up, which is what you really need to do in this situation. It'll just tend to fall back down. So we put this up there and then suture it into position. And I'm going to skip through suturing because that's always boring to watch, even though it's at high speed. And then a septal extension graft going in also to try to line her up on the midline of her Cupid's bow. So if the caudal septal edge is not lined up with the Cupid's bow, I'll use a septal extension graft on the opposite side just to line it up, because I like to use the tongue and groove, as you're seeing here, to set the tip basically in all of my rhinoplasties. So that's that going in. There we go. A little cephalic trim, just a little bit of contouring there. Alar spanning suture, not completely tightened down because she didn't want to change her tip that much, if at all. And you see how you're going to see how swollen she is in her early post-op photos in a minute. You can see how swollen she is there now. And so this is putting in the dice cartilage tissue glue. It's a thin graft in this case because we just want to put it over the top, mostly in the radix area. And you're going to see I'm going to pinch this just to get it to the length I want, which is the fun thing about these grafts. And then we're going to place it up there. And then I'm not so sure it shows, I'm going to show in this video, but I'm going to take some of this and also place it over the right side wall to augment it a little bit more. Okay, so here she is at 4 months. Much better dorsal aesthetic lines in the front view. She's very happy. She's very swollen in her tip, obviously. And here's her profile showing the radix being raised up with our graft. And here are her scores. Much better. Okay. Let's talk about really severe deviations now. And this is when the caudal septum is completely off, and no matter what you do, it's going to go that way. As they say, so goes the septum, so goes the nose. And in these cases, these cases for me are very frustrating. And I really finally got to the point where I started putting rigid fixation on that base to keep it vertical, because it always wants to cant no matter what you do. And this is a patient with a very severe deviation of her nose. This was, by the way, a traumatic injury. Let me go backwards. Traumatic injury. You can see I marked the glabella, the tip of the nose, and you can't really see the subnasale mark, and the Cupid's bow to see how far off patients are. So sequential osteotomies, rib graft, tongue and groove, and plate to the maxilla was the key for her to really help cant this into the right position. And this is this isn't that patient. This is an ASR being done. In this case, I'm going to put a plate in this particular patient because the same thing was happening where it was tilted. And I think I was going to use that for an extended spreader graft, which isn't going to be shown here. And so when you're plating, and this is septal cartilage, obviously, in this case, you put the small piece of mini plate on there and you suture it to it. Now, by the way, some tips about this. You know, I no longer use plates that long. I use very small bits at the very bottom to keep it, to help prevent it from getting exposed, which has happened a few times. And if it's way down in the premaxilla, it doesn't matter. Here you can see you can pull the dorsal septal construct if it's canted all the way over, and this rigid fixation helps keep it right in position. And you can suture it to it. This is now that patient. You can see this rib graft and this dorsal construct really wanted to go to the right, and I pulled it over and just sutured it to this rigidly fixed caudal rib graft. And here she is much straighter on the operating table. And here she is early post-op. And I'm glad I took this picture because This is her base view. This is only like a month afterwards. This is her. She hit her nose again and deviated a little bit more, but she's still much straighter than she was. And she's generally very happy. So this is her pre-op schnoz, and here are her post-op schnoz scores. So these, I don't want to, I've shown a bunch of plating stuff. This is not something I would do all the time, only in rare cases, because there are problems with plates getting bent if they hit the plate and things like that, and extrusion. So I would only use it in rare cases. It can be a way to correct crooked noses if you got severely crooked noses, and try to secure the base of the tripod in people with premaxillary issues. And the indications are really to only use it if all else fails. Severely crooked dorsal septal segments and rib. If warping is a concern, it can help with that, although it seems not to be with the other types of oblique carving that we do. And an asymmetric or absent nasal spine when you have nothing to fix to. And contraindications are anyone who's going to hit their nose, if they can hit their nose. Here's a patient who had multiple surgeries before and had a severe facial trauma, which was the cause of all of this. One of the things that bothers him is this piece of bone sticking out of his right nasal sidewall, you can see there. And here are his preoperative schnoz scores. And for him, we took him to the operating room, did sequential osteotomies, resected the bone spur with the piezo, ASR with premaxillary augmentation and a small plate, very small at the base, diced ribbon tissue glue and alar spanning suture with tongue and groove. And so here he is afterwards, looking much better. He's much happier. This is only 3 weeks. Why did I take the picture then? Because he lived far away and I didn't think I was going to ever see him again. But actually I did see him again 9 months after surgery. And the interesting thing was he had gone and had a forehead flap for basal cell carcinoma on the tip of his nose in the interval with someone else. And he has a scar on his forehead on the right side now, and a little, you can see a little scar at the medial part of his right eyebrow, and his tip of his nose is kind of bigger and shiny because it's forehead skin that's now on the tip of his nose. But he's still nice and straight. He's actually very happy. This is his early post-op. Here he is later. You can see the scar on the forehead there going up. And this is early and later side view. You know, he's a guy who had multiple traumas, but using this reconstructive technique, we were able to get him to a much straighter position and improve his breathing as well as his aesthetic concerns. Now, no talk would be complete nowadays without at least talking about dorsal preservation. So this is another way of treating crooked noses. And I don't want to belabor it too much because I think we're running out of time, but I want to just talk to you about this letdown method and my modification to it and what I do for asymmetric noses with this. So I watched for the last 15 years while people were talking about this, and I was very skeptical. And I know there are surgeons in Brazil who are very good at this. And my friend Fausto in Mexico City does this a lot, and Jose Juan in Mexico City. And so, but it was only in the last 4 years I was watching Eve and Barish do this, and I started thinking maybe I'll try this with an open technique. But what I really started doing, and I know 2 of my good friends in Europe are doing a similar thing to this, where they do a modified subdorsal strip. And what I started doing independently was something similar because it allows me to do the structural rhinoplasty things that I like to do. So we leave a subdorsal strip, make a cut in it, and then we flex the whole thing down into position and suture it with PDS. And I find this is good for me because I like to keep this caudal segment, this T-strut intact so I can do tongue and groove and all those other things that I like to do. And I didn't want to give up the way I do rhinoplasty in general. I just wanted to change the way I approach the osteocartilaginous vault. And so we've published this, a few papers about this out there. You can look for it, and describes the differences between Caudle's technique, Saban's technique, and the way I do it. And this is a schematic. But again, the key is for structural preservation, which is what I'm calling this general method, structural rhinoplasty and preservation of the dorsum. This T-strut, caudal strut is key, and we preserve it. Now, what you'll find is, you know, when you see this, what we do is take out the strip and we leave a 5 millimeter or so subdorsal strip present. And you can actually move that right or left. So in the, you know, for this talk, we're talking about asymmetric noses. You can move it to the right or left of that caudal strut if you want to shift it a couple millimeters. So rather than using spreader grafts or something in a patient like this, who has, as you can see, a slight deviation of her osteocartilaginous vault to the left, we can just suture it down, do all the letdown the same way, but just push it down onto the right a little bit. And so that's what we did. this is just showing this technique again, sorry, but in her, it was we sutured it so it was slightly to the right, 1 millimeter over. And what it allows us to do is to straighten a very minor deviation of the vault. This is what she looked like on the operating table. This is her 1 year post-operatively. I just saw her recently. But what I like is looking at the frontal view because I can see that she's a little bit straighter now. It's a subtle thing, but she also has very nice dorsal aesthetic lines. Nothing was done to the tip. Everything else was preserved. And so for me, this is very different from what I did for many, many years. And I really like the way this works in the right patients. This is showing this external incisions really not an issue in these patients. And so she had a little bit of congestion. I'm not sure why that got better. I really didn't touch anything there. Some people think that when you do this, the valves open a little bit, which may or may not be true, but she's very happy. It's another patient. She has a slight deviation of the osteocartilaginous vault to her left. She has other asymmetries. You know, in addition to all the things we did to her tip and all that, the structural preservation method allowed me to shift her slightly to the right and get her into a better position. So here's her 9-month follow-up. But I want to show you the frontal view where that subtle deviation to the patient's left is now corrected and fixing her tip onto that so she lines up better with her Cupid's bow at the same time. And this is a close-up frontal view showing that. Of course, she's wearing more makeup in the preoperative than the postoperative, but I think you can see what we did there. And these are her schnoz scores pre and post. Another one. Now, this is a more severe thing. So if you look and examine this patient, she has a longer nasal bone on her right than on the left. So the approach here for this is a little different, and this is purely cosmetic, no functional concerns. We do the letdown, but here we're going to do an asymmetric letdown where we only cut bone on one side and shift the whole pyramid to one side. And actually, I'm going to show this. We're going to measure from that dorsal midline how much the difference is to each nasofacial junction. And then, I think I measured it before, and then we're going to actually resect some bone corresponding to that on the opposite side. So you're going to see here, I'm going to take out a wedge of bone rather than doing a bilateral letdown. I'm only going to do a letdown on the patient's right. And so using the piezo, we can precisely do this. So we're just doing 2 cuts, and then we're going to go in and take out of this bone just on that side, allowing the whole pyramid to shift slightly to the right. In the interest of time, I'm going to skip. And then this is just showing, you know, the letdown, the subdorsal strip, modified subdorsal strip method, making this cut, preserving that caudal portion, which we will then do tongue and groove to and alar spanning sutures and all the other things that we like to do. I'll skip that just for time. So this is the Gunter diagram for what we did. I ended up using the SCG also to get the tip over. And you're going to see, this is the profile early. Again, a patient who should have seen me recently, but was canceled due to COVID and will hopefully see me soon. Improved symmetry, not 100%, but improved with shifting the bony pyramid using asymmetric letdown methods. And what I like about it is the dorsal aesthetic lines are just, I think, better. And so here are the pre and post scores, which are much improved aesthetically. Another patient, same thing. We're going to do asymmetric letdown, mild functional, but mostly cosmetic. Asymmetric 3 millimeter letdown on the right to shift the whole bony pyramid to that side, SCG, and the modified subdorsal strip structural preservation method. And here she is post-operatively. And, you know, I think she looks really good. She's about 6 months out. Here's her 3/4 view, also a slight hump reduction for her, and base view. And this is her pre and post schnoz scores. So just a couple last comments about pitfalls. Why do we get crooked noses? Well, in a Joseph rhinoplasty, we're taking off the dorsum and we're doing osteotomies to narrow and reconstruct the midvault. The problem is, what if there's a high dorsal septal deviation? Somebody who looks symmetric to start, but ends up asymmetric afterwards. How does that happen? Probably something like this. And you know, when you cut off that dorsum, suddenly you look down and you see there's a bigger gap on one side versus the other. This happens all the time. And now I talk to my fellows and my residents about favorable versus unfavorable situations. And if a patient is deviated in one way and the bones don't want to go that way, then that's an unfavorable situation. So here, when you do this, this is going to fall more on one side. And you can try to correct it with spreadographs and so on. But the problem with that is you're going to end up with a flat top. So you're really stuck. You can try to move that septum over, but in my opinion, that doesn't work very well. So in class, this is the only classification I'm going to tell you, favorable versus unfavorable. If you do a Joseph hump reduction and the septum is to one side or the other, and you have a deviation of the nose, there are favorable situations and non-favorable. If you're looking at a dorsum now, this is an open roof with the red line being the septum. If the nose is deviated to the right and needs to move to the left, and the septum is on the concave side, that means the nasal bone will move more on the side you want it to move on, and you'll have a favorable sort of situation. If the septum is on the opposite side, it'll prevent that nasal bone from moving in, and in fact, the concave side will fall in more towards the convex side, no matter what you do, and you'll actually have an unfavorable situation, and that may be what happened to this patient who came to me for revision. And so this is the type of thing you want to avoid. So when you see that, you have to put spreadographs in, and you might end up with a flatter top. And so this is, a patient who had a revision. The answer is to put a spreadograph in there and try to open it up and make her look more symmetric. Obviously, other things were done, so I'm going to skip through that. But I think, this can also happen in the letdown. So it's not immune to this problem, but we call it axis deviation of the dorsum when this happens. And that's if, again, to show this, if you do a letdown or a push down and the septum pops to one side or the other unintentionally, because in the other ones I did that intentionally to make them look straighter. If you do this unintentionally, it won't just look like it's off to one side. It'll actually twist. It can actually twist one way or the other, and you can end up with a very unusual looking dorsum. So I think this Joseph and letdown or preservation methods are both potential causes of dorsal deviations. You have to be very careful with both. And I think that anyone who says that one is plainly better than the other, I don't think that. I just disagree with that statement. I think that you have to do what works for you and recognize situations where you might have to do one versus the other. And this is just the last case showing a twisted lower portion and also asymmetric nasal bones in a revision case, which we treat with a unilateral spreader graft, anterior septal reconstruction, no plate, just putting it into the groove, and alar spanning sutures and tongue and groove to kind of get everything into a more symmetric position. And again, there are some facial asymmetries here. You can't get everything 100%, but you can improve things for these patients. And these are her pre and postoperative schnoz scores. So to finally say again, the aesthetics and function are both very important. In crooked noses, you have to look at the position of the piriform aperture, the nasal apertures, the maxillary spine and septum, and balance that with function, because you can try to straighten a nose, but it may not actually work well. So you have to keep that all in mind. And all faces are asymmetric, and careful analysis is critical to planning. Counsel patients with regards to expectations. Consider the thirds of the nose, the upper third, middle third, lower third. The bony vault I like to treat with sequential osteotomies, but you can use camouflage grafting in any of these cases. Mid-vault with spreader grafting or caulking sutures. Caudal portion, I like to use anterior septal reconstruction. Camouflage if necessary after all of these things, if everything else fails. And dorsal preservation and asymmetric letdowns are good for straight deviations where the nasal bone length is asymmetric and you just want to shift things over. What I like to tell everybody who's out there learning, even folks who've been out in practice for a while, do not stop learning and innovating, and do not be satisfied. I don't do rhinoplasty the same way today that I did 5 years ago, 10 years ago, or 15 years ago. And always try to learn new things. And I learn a lot from watching a lot of webinars like this. I hope maybe a couple of things here struck a chord with some of you out in the audience. And this is my contact information. And I want to thank, again, the panel for having me. Thank you very much. It's been a real honor, and I look forward to any questions you might have.
Thank you, Dr. Sam. It was a great lesson. We have some questions from the audience.
Sure.
We're going to start. Gonzalo, He was asking you, how do you treat an ethmoid perpendicular plate that deviates into the dorsum and keep the nose deviate after the osteotomy? Sorry.
So that's really just the problem I was talking about with when you do a dorsal hump reduction, Joseph method, and there's a high septal deviation, and it's unfavorable. Because if it's favorable, it's deviated towards the side that makes it easier for you to make the nose straighter, that's fine. But if it's deviated the other way and you can't move the nasal bone, then you need to mobilize that. So here's the problem. If you're doing an anterior septal reconstruction or an L-strut septoplasty, you need to keep the keystone intact. And if you do what you really need to do, and that's mobilize the whole ethmoid plate over by doing an osteotomy, which you have to do very carefully because of the skull base, you will detach the keystone. It's a challenging problem. I think that if you're doing a full, a full septoplasty and everything, you need to be very careful and be ready to reconstruct the keystone if you start to partially cut the perpendicular plate of ethmoid and bring it over. You can do a partial cut and try to suture it to the other side. I didn't show this, but sometimes you can put drill holes in the nasal bones and shift them over. That's actually how you repair a keystone. But that is the very problem that's very difficult, I think, to treat. I think that some people with high septal deviations, if you can recognize it beforehand and you're doing a dorsal hump reduction, are good candidates for dorsal preservation, because you can just drop the dorsum down, forget about the high dorsal septal deviation and just hide it just like it was hidden before and not worry about it.
Thank you. Also, Lena Ramos is asking you about the use of Botox. Do you think that the nasal muscles have an important role in some case of crooked nose? Do you use Botox post-op in that case?
That's very interesting. I have not explored that. I haven't seen that really be a big issue for me, but that's an interesting concept and I'm interested in learning more about it. I suppose you'd have to do the injection about a week before your surgery so that the Botox has its effect before you do the manipulations. But I'm curious as to which muscles you'd inject which would be causing this. But I personally think, that elevation of the skin envelope, skin soft tissue envelope when you're doing this type of thing is important to allow redraping in a new position. And I think that's probably more important for me, but I haven't explored the muscle thing. Haven't tried it.
Thank you.
I have one question regarding that. Do you think that the piezo osteotomies, since that they are not fully disconnected of the soft tissue underneath, do you think they can return to the original position as it was before more easily than the traditional osteotomies?
Well, that's because you're assuming that you cut the mucosa when you do traditional osteotomies. You're not supposed to.
Yeah.
It's just more likely to happen. And by the way, piezo can cut through the mucosa just from the force of it going through when you cut through. So neither of them are perfect. But, I think it's probably okay. I think the mucosa, because that flexes. I'm more concerned about the external soft tissue envelope because that puts pressure down on it. If you leave the bones, everything attached, and you kind of move it over, it's going to, there's more tension on it to pull over it. It's also just thicker. So I don't know the answer to your question, but I don't suspect that it's a big problem.
And in which cases do you use piezo or the traditional osteotomies?
I started using piezo. I don't remember if you were still here when you were here when I started using it, or was it after?
Yes. Okay. When I went there, you were starting to use it 2 years ago.
I'm much more comfortable with it because I use it all the time now. But I did a couple of, Joseph hump reductions with osteotomies in the past week. So I can go either way, but I do use the piezo much more often now. I think especially if I'm doing fine work and want to shape the bones. Another thing that I didn't really share was that, with the piezo, you can really finely rasp bones that are asymmetric and change the shape a little bit, almost like you're shaving down on an eggshell. I mean, you can be very fine with it. So it is nice that way. So I often use it now.
Nice. Thank you.
Mhm.
Do you have any more questions?
Ingrid, do you have any questions?
Thank you, Dr. Sam. Great lecture. And do you have any questions? Do you have, Dr. Carlos? It's late here.
I know, I feel bad for you guys. It's very late for you.
Yes, but we are here.
Have some
Do you have
questions?
any words of wisdom for how you approach crooked noses, any of you? Anything that, you know, there's so many different ideas and approaches that,
No, I think you summarize everything we really do. And I think that's my opinion, that in crooked nose, you can do everything, but all these things along the time can mobilize again the nose because of the because all of the tissues that are rearranging and camouflage. I think it's one of the things that is really important, because all the noses that are crooked, and we try to move it straight, and it's everything okay. We think it's everything okay, but there are some irregularities that we can camouflage, and I think that this is one of the best things to do at the end of the surgery. I don't know. What do you think of that?
oh yeah, absolutely. And you saw a few cases where I did that. I mean, I like to think of things in terms of all the structural stuff that I can do to get things to look as good and as functional as possible. And then at the end, camouflage things that still need a little bit more work. And so there's a stable structure underneath, and then you can put a little camouflage on top. And I think that's, yeah, I agree, absolutely.
Yes, and I think Gubish has outstanding results, outcomings, because he camouflaged a lot of noses.
Yeah.
He put free diced on a lot of
virtually
noses.
every extracorporeal septoplasty gets free diced cartilage over the top.
Yes.
Yeah.
But an outstanding lecture, very elucidative. I don't know if I can say that, but we learned a lot with that lecture. We could summarize, synthesize everything in a crooked nose. So
Yes.
I'd like to thank you very much for your time to give us this class, and we are everywhere, every time you want to come here in Brazil, you are invited.
Oh, thank you. I'm not sure they're going to let, you know, any of us travel anytime soon, but I'd love to come down and see you all again. Thank you very much.
Okay.
My pleasure, my honor to be here. I know it's very late for all of you, so I appreciate you accommodating this time difference with me. So thank you very much.
Thank you.
It was a very, very good lecture. Thank you so much.
Thank you. I hope you all have a great night and be safe. And I look forward to seeing you in person.